Yes, I hope the audio and video is clear. Good afternoon. And myself, Dr. Bharath Kumar. I'm the pharmacology faculty. And today we'll be going to discuss the formal medical graduate exam T&D pattern of questions. So before I commence my classes, I just want to confirm whether the audio and video is fine. If everything is fine, then I will be starting my classes. So waiting for your feedbacks. Yes. Yes, I am waiting in the Behtareen Bhatia T&D. Everything is fine. Can we move on? Okay. Is it fine, AR? Just confirm me whether everything is fine, then we'll start the T&D. We put a message. Okay, so hope everything is fine, guys, and let us start our discussion. Let me tell you that we'll be discussing T&D pharmacology, and we'll start with the first question. Yes. Yes, number one, aspirin and phenobarbital are acidic drugs, whereas diazepam is basic drugs. Which one of the following is false is the question. So the statement is aspirin and phenobarbital are acidic drug, whereas diazepam is basic drug. You have to find out the false statement. Aspirin is present mainly in non-ionized form in stomach. B. Diazepam is absorbed from small intestine. Phenobarbital is an enzyme inducer and increases the duration of action of concomitant drug administered. Diazepam after metabolism gives rise to reactive, that is active metabolite. So is the right answer here? Yes. To understand what is the right answer, first of all, let us understand what are the principles of drug absorption. What we need to understand in the principles of drug absorption. So first and foremost, a drug has to get absorbed should be non-ionized. If the drug is non-ionized, it can easily cross the membrane. It can easily cross the membrane. It can easily cross the membrane if it is non-ionized. What is the other name for non-ionized? It is also called as lipid soluble. So a drug which is lipid soluble can easily cross the membrane. Now you need to understand that drug is available in two forms. One is either it is weak acid or it is available as weak basic drug. So it is a weakly acidic drug or weakly basic drug. If you place weak acidic drug in acidic medium, so what happens is if the drug and medium is same, then the drug is non-ionized, that means lipid soluble. So if it is lipid soluble, then it will easily cross the membrane. So if it easily crosses the membrane, I told you it can easily get absorbed. Same thing with weakly basic drug. If you place it in alkaline medium, so what happens? It will also become non-ionized, that is lipid soluble, and crosses the membrane. So the drug is easily absorbed. So this is a basic concept. But if you make these changes ulta, if you place acidic drug in alkaline medium, or if you place basic drug in acidic medium, then the drug will become ionized and what we call it as water soluble. It will become water soluble and it will get easily excreted out. So let us see the options now. Yes. Aspirin is present mainly in non-ionized form in the stomach. Is it true? What is aspirin? They have given aspirin. Aspirin is an acidic drug. So an acidic drug is present in the stomach means the stomach pH is also acidic. So an acidic drug aspirin present in stomach will be non-ionized form. Yes, it's a true statement. It's a true statement for us. Diazepam is absorbed from small intestine. Is it so? They are given diazepam is basic drug. And you know that basic drug, if you place it in small intestine, the pH is a bit alkaline. So here it will become lipid soluble and easily absorbed. This is also a true statement. Now phenobarbital is an enzyme inducer and increase the duration of action of concomitant drug administered. So phenobarbital is an enzyme inducer. Now what do you mean by an enzyme inducer? Enzyme inducer is a drug which can increase the synthesis of drug metabolizing enzymes. So what happens when you increase the drug metabolizing enzyme? If I give another drug, for example, warfarin, what happens to the duration of action? The duration of action of warfarin decreases. So decreases duration of action of warfarin. The reason is it will increase the enzyme and increase the metabolism of the concomitant drug warfarin. So what happens with the enzyme inhibitor? An enzyme inhibitor will inhibit the enzyme. So what happens if, for example, I take warfarin? If I give warfarin with phenobarbital, not phenobarbital, either enzyme inhibitor, so they will inhibit the metabolism of enzymes. So they will increase the duration of action. So in short, you need to understand two important points, guys. If you are using an enzyme inducer, remember an enzyme inducer, it increases the enzymes and decreases the duration of action. If I give an enzyme inhibitor, it inhibits the enzyme and increases the duration of action. This is the meaning. Now you tell me, I will give an example. Rifampicin plus OCPs. So rifampicin is an enzyme inducer. Now tell me what happens to the OCPs. Will they increase the duration of OCP or decrease the duration of action of OCP? I will waiting for your answers. Now here phenobarbital is an enzyme inducer, increase the duration of action. No, it will not increase the duration of action. It will decrease the duration of action. That is a false statement. Diazepam after metabolism give rise to active metabolite? Yes, true. So diazepam after metabolism will give rise to non-diazepam, which is also active. So this is also a true statement. So after metabolism, what happens is diazepam will give rise to non-diazepam. Both are active. Then what is the meaning of prodrug? Prodrug is nothing but a drug which is inactive and after metabolism it will become active. That is called prodrug. For example, levodopa. So levodopa will be metabolized by decarboxylase into dopamine. So that will become active. So this is an example of prodrug. So what did I ask you guys? If I use rifampicin with OCPs, what happens to the duration of action of OCP? Rifampicin is enzyme inducer. The duration of action of OCPs decreases. So this will lead to contraceptive failure. A very commonly asked question. Contraceptive failure. Yes, come on guys, you have to answer this. So it will be easier if you are answering. So we can make this worthful if you are answering in between. Even if you make mistake, no issues. So contraceptive failure occurs. Yes. Now we have a list of enzyme inhibitors and inducers for you. Inhibitors, you can remember by the mnemonic, vitamin K cannot cause enzyme inhibition properly. So V stands for valproate, ketoconazole, cimetidine, ciprofloxacin, erythromycin, isoniazid, and protease inhibitor. The inducers are GPRS cell phone, griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and phenobarbital. So these are inducers. So can you repeat again? Enzyme inhibitors will inhibit the metabolism and increase the duration of action. Inducers, they increase the enzymes activity and decrease the duration of action. So there's a list of enzyme inducers and inhibitors. Now let us move to the next question, this one. So second question is, which of the following is correct regarding the mechanism of action of thyroid hormones T4 and T3 at thyroid hormone receptor? Do they activate phosphatidyl inositol? DAG calcium cascade? It is nothing but IP3 DAG pathway. Or will they act by increasing cyclic AMP? Will they activate tyrosine kinase enzyme? Or will they activate nuclear transcription factor? This is the question. Now, in the classes, we tell you what are the receptors on which the drug works. So let me tell you what are the receptors on which the drug works. Suppose this is the cell. So this is the cell. And cell membrane. There are two types of receptors. One is present in the nuclear. We call it as nuclear receptor superfamily. And the one which is present on cell membrane. So what are the nuclear receptor superfamily receptors? The nuclear receptor superfamily receptors are the corticosteroids. In corticosteroids, we have two types, the glucocorticoids and mineralocorticoids. Then we have the sex steroids. What are the sex steroids? We have the progesterone, testosterone, and estrogen. Then we have the vitamins A and D. And also we have thyroxine, which acts through nuclear receptor. And then we have PPAR gamma or PPR. So all this, they enter the nucleus and they increase the protein synthesis. So that is by transcription. They increase protein synthesis. So that is their mechanism of action. Now the drug which present in cell membrane, there are three types. Number one, which acts through ion channel receptor, and the one which acts through G protein coupled receptor. Now the one which acts through G protein coupled receptor, we have three varieties in that: GS, GI, and GQ. The name GS stands for it stimulates an enzyme called adenyl cyclase, and that will increase cyclic AMP. It increases cyclic AMP. And GI inhibit adenyl cyclase, and that will decrease cyclic AMP. And the GQ is going to activate the IP3 inositol phosphate and diacylglycerol pathway. So this is GPCR. One more that is present on cell membrane is the transmembrane enzyme receptors, that is tyrosine kinase, and that which acts through JAK-STAT. The one which acts through tyrosine kinase is insulin growth factor 1. Then any growth factors will be through tyrosine kinase. For example, those cause cancer, those are growth factors, vascular endothelial growth factors, epidermal growth factors. So any growth factors is going to increase the activity through tyrosine kinase. JAK-STAT is growth hormone, prolactin, interleukin, and cytokines. So these act through the JAK-STAT pathway. Now coming to ion channel receptor, the meaning is they conduct ions. So that's why the ions will enter inside. The examples are nicotinic receptor. Then we have GABA A, 5-HT3, then glutamate. So they conduct ions, that's why they are called ion channel receptor. So if you know these basics, now let us come to the question. Thyroxine acts through nuclear receptor. That means it has to activate the nuclear transcription factor. So that is the mechanism of action. The answer D is correct for this. What about other options? The other options here is activate phosphodiazole inositol, DAG, and calcium. It is through GQ receptor. Increasing cyclic AMP is by GS coupled receptor. I told you activating tyrosine kinase is by either insulin or insulin-like growth factor 1, or any growth factors is going to be tyrosine kinase. Now please remember, the one thing you will make a mistake is growth hormone and growth factor. Growth hormone is JAK-STAT. Growth factor is tyrosine kinase pathway. Right? Yes, guys. So just put a thumbs up. You are following, and then I can continue. Thakur, Nafisa, AR. So tell me, guys, whether you're following. So with that, we are done with the second question, and the answer for that is D. The answer for that is D. Clear? Yeah. Now moving on to the next question. Third question. 32-year-old patient had anaphylactic shock and was given adrenaline 1 in 1000 by IM route. The actions of histamines are antagonized by adrenaline. This type of antagonism is called. What is that antagonism called as? Chemical antagonism. What is the meaning of chemical antagonism? The meaning of chemical antagonism is, suppose we have HCl, acid, and if we give antacids, antacids are basic in nature, so there will be a chemical reaction and there should be neutralization. So that type we call it as chemical antagonism. There should be a chemical reaction. For example, I will give one more. You know heparin. Heparin is acidic in nature, and the antidote for heparin is protamine. So when we use heparin, for heparin over toxicity or overdose, the antidote is protamine. And how is it neutralized? The antagonism is chemical, because heparin is acidic, protamine is basic. What is competitive and non-competitive antagonism? Now let me take one slide and tell you what is competitive and non-competitive antagonism. Competitive means, and what is non-competitive? Suppose we have a receptor. This is a receptor, and we have one more receptor like this. We have a concept called agonist. You know, agonist bind to the receptor and produce the response +1, and antagonist bind to the receptor and produce the response 0. So if they both compete for the same site of the receptor, we call it as competitive antagonism. So it is called competitive antagonism. What is non-competitive? Here the antagonists bind to a different site. So we call that site as allosteric site. And the agonist try to bind here, but it cannot bind it. But can you overcome this antagonism? Yes, you can overcome this by increasing agonist concentration. By increasing agonist concentration, you can get the same response. You can get same response. But here, even if you increase the agonist concentration, the response will not change. Actually, the response decreases. So what is the example for that competitive antagonism? It is acetylcholine and atropine. So acetylcholine and atropine acting on muscarinic receptor. That is called the competitive antagonism. Guys, you tell me, for atropine poisoning, what is the antidote? And what is the antidote for OP poisoning? I am waiting for your answers. What is the antidote for OP poison? And what is the antidote for atropine poison? Waiting for your answers. Come on. The non-competitive antagonism example is, on the GABA A, we have benzodiazepines, which binds to different site, and bicoculin, which binds on the different site. So that is an example. So can somebody tell me what is the drug of choice for organophosphate poisoning, and what is the drug of choice for atropine poisoning? Anybody? Yes, you know the answer. Come on. OP poisoning, the drug of choice starts with P. It is none other than physostigmine. Is it so? Is it so? You have to correct. No, it is not a drug of choice. So physostigmine is the drug of choice for atropine poisoning, because Physostigmine is an anticholinesterase and which will increase acetylcholine. But in OP poisoning, the drug of choice is atropine, because in OP poisoning there will be excess of acetylcholine and you can overcome that by blocking muscarinic receptor. So OP it is atropine poisoning it is physostigmine guys. So don't confuse that. So acetylcholine atropine acting on that is called competitive antagonism. So here the antagonism between the adrenaline and histamine is not competitive or non-competitive. Then what is physiological antagonism? Now physiological antagonism means, let me take a bronchus. Suppose this is a bronchus and adrenaline acts on its own receptor, that is beta 2, and histamine acts on its own receptor H1. It causes bronchoconstriction and adrenaline causes bronchodilation. Now, how do you call it as physiological? Number one condition is the receptor should be different. Is it different? Yes, it is different. And the action should be opposite. So this is the point where you have to understand that this is physiological antagonism. Number one, the receptor should be different. Yes, this is beta 2, this is H1. The response should be opposite. Yes, bronchoconstriction and bronchodilation. So that's what happens when we give in anaphylactic shock adrenaline. Allergy or anaphylaxis is because of histamine and the physiological antagonist is adrenaline. So the right answer is D. This is the right answer. Now before I stop this question, I want to ask you one more thing. Suppose there is glucagon and insulin. So glucagon, you know that it increases glucose and insulin decreases glucose. Tell me guys whether this is physiological antagonist or not. Yes or no? Please, I am waiting for your answer. Prithvi, Nafisa, studying, Sub-Zero, Thakur. Please answer that. One more important they ask you in exam is the dilution of atropine. How much dilution of atropine do you use it? Please understand that. 1 in 1000 dilution of atropine is used in intramuscular or subcutaneous or by nebulization, and that is used in anaphylaxis. Now 1 in 10,000, when do you use this? This dilution should be used when you use adrenaline IV or intraosseous. In that case, we have to use this 1 in 10,000. 1 in which condition should we use this, intravenous or intraosseous? Whenever there is cardiac arrest or anaphylaxis. In that cases, we use this 1 in 10,000. Now moving on to 1 in 50,000 to 1 in 50,000 to 1 in 2 lakh. So this is used, adrenal dilution is used along with local anesthesia. So the drug of choice for anaphylactic shock is adrenaline and it is 1 in 1000 intramuscular, and that is what we give for anaphylaxis. Nafisa has told that this antagonism is physiological. Yes, because now what is the rule number one? Rule number one, the receptor should be different. Yes, insulin acts on tyrosine kinase and decreases glucose, and glucagon acts through G protein couple receptor and increases glucose. So first and foremost, I told you two important things to remember physiological antagonist. The receptor should be different. Is it so? Yes. The second option is the response should be opposite. Yes, it decreases glucose, this increases glucose, the response is opposite, so it is a physiological antagonist. Yes guys, it is a physiological antagonist. You're right. So answer for this question is D, physiological antagonist. And I've given one more clue in this question. The drug of choice for anaphylactic shock is injection adrenaline 1 in 1000 by intramuscular route. It's a very repeatedly asked question. Suppose if they ask you the dose is between 0.3 milligram to 0.5 milligrams. So that is the dose what we use for the anaphylactic shock. Very, very repeatedly asked question. Yes. Now moving on to the question number 4. During drug development, NDA stands for New Drug Application filed in office of FDA at what time? So in our country, we call that FDA as DCGI, Drug Control General of India. So we call it as Drug Control General of India. So Drug Control of General of India, where we apply this application. So in a clinical trial, first and foremost, what we do is animals first find out the source. First we find out the source, and after we find out the source, what we do is a preclinical trial. So preclinical trial is nothing but a trial done on animals. That is called preclinical trial. So just a minute. So that is called preclinical trial, where we do the animal studies. So once we do the animal study, then you have to apply for an application that is called IND, Investigational New Drug Application, and that has to be seen by DCGI. Now after that, you can start the phases, that is phase 1, then phase 2, then phase 3. So once you complete this phase 3, then you have to, the company will apply for one more application that is called NDA. NDA stands for New Drug Application. And once you get that new drug application, you will get a license called marketing license. Marketing license. Yes, I think many have answered this. Yes, so marketing license. So once the marketing license is obtained, should we do one more phase of study? Yes, we have to conduct one more phase, that is called phase 4 study. And that's why phase 4 study is also called as post-marketing surveillance. So in a new drug development, first you have to find out the source, then we do animal studies, and then you start with human studies. Phase 1, phase 2, phase 3. And after you've done that, we apply for one more license, NDA, for marketing license, and what we do is phase 4 study. So they have asked, during drug development, NDA filed in office of FDA at what time? After completion of preclinical trial? No. After that, what we do is IND application, that is Investigation New Drug Application. This is ruled out. After phase 1 of clinical trial, no, after phase 1 we do phase 2. And remember, when you do this phase 1, 2, 3, you require ethics committee approval. So they will have to approve that trials. And in phase 1, we involve human healthy volunteers. So human healthy volunteers are involved in phase 1 trial, and we mainly check for safety, whether drug is safe or not, and we check for maximum tolerated dose. What we do in phase 2 is we check for efficacy, and also we check for dose ranging. And maximum drug failure occurs in phase 2 trial. So after phase 1 is ruled out, after phase 3 trial, yes, after phase 3 trial, we give this ND application. After discovery of lead compound, that is after the source is lead compound. So after that, we do preclinical trial. So what do you do in phase 4 trial? I think now the vaccines have come out, and why are we still doing studies? Because we want to check what happens when the drug comes to the market. What are the long-term side effects? So what happens if I give it to the pregnant, children, lactating, and elderly? And we check for drug interactions. To check all these things, we do this phase 4 trial. So the question here, the answer for this is option 3. After phase 3 of clinical trial, we apply for new drug application. So please remember, let me tell you again, human healthy volunteers, phase 1. The main aim of phase 1 is safety. We also get for maximum tolerated dose. Phase 2, we check for efficacy and dose ranging, and more drug failure occurs in phase 2 of the trial. Right? Phase 4 is also called as post-marketing surveillance. It is also called as post-marketing surveillance. Okay. Okay, guys, just respond. You are following. So in between, you answer the questions. It will be very happy. The fifth question, an elderly man was brought to the emergency room after ingesting a large quantity of metoprolol. Which of the following is used as an antidote? What is metoprolol? Remember, anything ending with LOL. LOL is a beta blocker. So patient has taken beta blocker in large quantities and he has come to the casualty. What is the antidote for that? Is it fomepizole? Now, fomepizole is an antidote for ethanol poisoning or alcohol. Yes, glucagon is the antidote for beta blocker toxicity. The glucagon acts through its own G protein coupled receptor and it can increase the heart rate, conduction, as well as contraction in the heart. So what happens when metoprolol is taken too much? The beta blocker toxicity will decrease heart rate, conduction, and decreases contraction. So that is reversed by glucagon. That's why that is the antidote. Naloxone is an antidote for opioid poisoning. That is, a morphine poisoning, the drug is naloxone. For carnitine, it is a drug of choice for valproate. You know, valproate is an anti-epileptic. Valproate induced hyperammonemia. So if the ammonia is too high, then we use carnitine. That is because of valproate. So the answer here is, guys, B, glucagon as the antidote for metoprolol overdose. Now, I have made a list of antidotes which will be very useful for you. Let me read them out. Number 1, for organophosphate and carbamide poisoning, the antidote is called atropine sulfate. For atropine poisoning, the antidote is physostigmine, and you are given that answer right. Beta blocker toxicity, it is glucagon. At least one question comes from antidote list. Paracetamol toxicity, N-acetylcysteine, it is N-acetylcysteine. Digoxin toxicity, it is digibind, also called as digifab. Cyanide toxicity, what we use is hydroxycobalamin and sodium thiosulfate. So the best drug is hydroxycobalamin. Heparin and low molecular weight heparin, the antidote is protamine sulfate. Warfarin overdose, it is vitamin K. For dabigatran, we use idarucizumab. So remember, dabi starts with DA, idarucizumab starts like that. Oral 10A inhibitors, we use andexanet alpha. For benzodiazepines, Z-drug and beta-carbolin, we use flumazenil. I know you will confuse flumazenil with fomepizole because both of them start with F. How to avoid confusion? Remember, ethanol, or you can write it as alcohol, any alcohol. So it starts with OO. They have OO. The antidote also has two O's in its name, fomepizole. But if you see flumazenil, it doesn't have any O. So remember, for ethylene glycol, methanol, ethanol, all this alcohol poisoning, the antidote is fomepizole. Valproate hyperammonemia, it is carnitine, just now I told you. Neural malignant syndrome, guys, this is one of the commonly asked question in your exam. The drug of choice is dantrolene. The drug of choice is dantrolene. And if they ask you specific antidote, then your answer should be bromocriptine. Otherwise, if they ask you drug of choice, it is dantrolene. Opioids such as morphine or any opioid, the drug of choice is naloxone. Sulfonyl-induced hypoglycemia, it is octreotide. So whenever we use drug and there will be dystonia, drug-induced dystonia, we use central anticholinergic like benztropine. We can also use benzhexol. For methotrexate toxicity, we use leucovorin. Calcium blocker toxicity, we use insulin, or we can use calcium gluconate. Methemoglobinemia, we use methylene blue. INH induced seizures, we use pyridoxine. Suppose there is fibrinolytic overdose, we use antifibrinolytic like epsilon aminocaproic acid and tranexamic acid. So at least one or the other question will going to come for this antidotes. So this is the list, guys. You have to revise them before your exams. You have to do that. So the question is this: metoprolol overdose, the antidote is glucagon. That is the answer. Moving on to the next question, question number 6. A patient 58-year-old had laryngeal cancer and undergone neck irradiation. After that, she had decreased salivary secretion and dry mouth. Which of the following drug is avoided in this patient? So patient is already having decrease in salivary secretion and dryness of mouth, which you should not use. What about cevamelin? Cevamelin is M3 agonist. So a muscarinic agonist will increase salivation. So because of that, we can use it in this patient because he has dry mouth. Can we use glycopyrrolate? Now glycopyrrolate is an anticholinergic drug. What do you mean by anticholinergic drug? This anticholinergic drug will block muscarinic receptor. That is the meaning. So when you block muscarinic receptor, the problems, what happens is dryness of mouth. So patient will complain of dry mouth. Then they will complain of blurring of vision. So they will have blurring of vision. Then constipation, then urinary retention. So these are typical of anticholinergic drugs. So here the patient is already having dry mouth and decreased salivary secretion. So we should not use glycopyrrolate. This is the answer. And we also use glycopyrrolate for mainly pre-anesthetic medication. We use that in pre-anesthetic medication. Just a minute, we have some technical problem. Yes, so we are back. So we use glycopyrrolate as pre-anesthetic medication. Why? Because when you post a patient for surgery, there is chances that he may have secretions from the lungs. He may secretion from the stomach, which he may get aspirated. To decrease those secretion, we use this before anesthesia. Suppose we have two options, glycopyrrolate and atropine as pre-anesthetic medication. Which one will you prefer, guys? Which one will you prefer? That is my question. Nikki, Ritika, Nafiza, Prithvi, tell me the answer. Whether you will prefer glycopyrrolate or atropine. Coming to other options, we should not end up here. We will read the other option also. Anticholinesterase drugs. What is the meaning of anticholinesterase? Suppose this is the synapse. So we have acetylcholine here And this acetylcholine is broken down by the enzyme cholinesterase. So the enzyme cholinesterase will break down that. Suppose I inhibit this, those drugs which inhibit this are called anticholinesterases. So they are also called as indirectly acting drug. Why they are called indirect cholinergics? Because they don't act directly, they inhibit the enzyme and then they increase acetylcholine. That will go and work. So can we use that in this patient? Yes, because parasympathetic increases salivation. That is also possible. Again, a drug pilocarpine, it is also a cholinergic drug which is directly acting. So that can be used for this patient. That can be used for this patient, but not glycopyrrolate because it causes dry mouth. Suppose we have option of atropine and glycopyrrolate. I asked you a question, which one is preferred, guys? It is glycopyrrolate for pre-anesthetic medication. The reason is atropine crosses blood-brain barrier and it may cause confusion in the patient. But glycopyrrolate will not cross the blood-brain barrier and it will not cause that delirium confusion in the patient. That's why pre-anesthetic medication, what we prefer is glycopyrrolate. Yes, Nikki, Nafisa, you are right. You are right. So the answer for the question is B, glycopyrrolate. B, glycopyrrolate. So one more question they keep on asking you is the drug for overactive bladder. Now what do you mean by a overactive bladder? It is nothing but a condition where the bladder is emptying repeatedly, for example in UTI. So it gets irritated and patient has to go to the urination. For that, what is the drug used? You can remember by the mnemonic my friend dost. What is that my friend dost? Yeah, my for mirabegron. So mirabegron is nothing but it's a beta 3 agonist. It's a beta 3 agonist. Friend is fesoterodine, flevoxate, D for darifenacin, oxybutynin, and one more is onabotulinum toxin. Can anybody tell me what is the mechanism of botulinum toxin? Yes for solifenacin, tolterodine, and trospium. So these are for overactive bladder. Now coming to drugs for atonic bladder or the drug used for post-op urine retention are bethanechol, pyridostigmine, neostigmine. These are used for the atonic or post-op urine retention. So I asked a question, how does botulinum toxin work? These toxins work by decreasing acetylcholine release. They act by decreasing acetylcholine release from pre-synaptic terminal. Right, so that is the mechanism of botulinum toxin. Where do you use botulinum toxin? We use it in cosmetically for wrinkles, if a patient has wrinkles, or a glabellar line, any muscle spasms, there we use it locally. So that is the point I had to tell you. So coming to this question number 7, a patient was put on topical drug for open angle glaucoma. Now he presents with macular edema and iris pigmentation. You can see here. If I enlarge this image, you can see the iris is pigmented in a different color. So they were asking which anti-glaucoma drug was used so that it caused macular edema. Number one option is dipivefrin. Dipivefrin is a prodrug. And it gets converted into adrenaline. So adrenaline. So the adverse effect of this drug is mainly causing black conjunctival pigmentation. Black conjunctival pigmentation, that is dipivefrin. Bimatoprost belongs to prostaglandins. So what does it cause? Remember, most common question asked for adverse effect is prostaglandins. What does it cause? It can produce macular edema. It can produce macular edema, then growth of eyelashes, so increased growth of eyelashes, then they can produce iris pigmentation, and one more thing is they can produce, I'll move it here, orbital fat atrophy. They can produce orbital fat atrophy. So the answer here is the drug which causes that is bimatoprost. Ecothiopate is a cholinergic drug. It can produce cataract and it can produce a retinal detachment. Apracnodine is going to produce lid retraction. We have a similar drug which is going to be called as the alpha antagonist, that is called brimonidine. The specific adverse effect about brimonidine is it causes anterior uveitis. So it causes anterior uveitis, that is brimonidine, and it can also cross the blood-brain barrier and may cause CNS depression. So the major question that is asked is about the prostaglandins adverse effect. Now, what is the mechanism how bimatoprost works in glaucoma is it decreases, it decreases? No, it increases uveoscleral outflow. How come miotics work? Like ecothiopate, they increase trabecular outflow. Apracnodine, brimonidine decrease the aqueous humor synthesis. Dipivefrin also decrease aqueous humor synthesis. Can you tell me other drugs which are used in glaucoma? Because yesterday we are done with the ophthalmology. I think you would have revised that ophthalmology. Can you tell me two more drugs which can be used in glaucoma? Yes, I'm waiting for your answers. Two more drugs used for glaucoma. Yes, come on guys. Yes. Two more drugs are number one, beta blockers. You can also use beta blockers, and we have a new drug that is called natracidil, which is a Rho kinase inhibitor, which can be used for these conditions. So answer here is B, bimatoprost. Now let us move to the next question. Question number 8. A 42-year-old patient came with redness and pain in right great toe. So whenever you get that question, redness and pain in the right great toe, you have to think of gout. His uric acid level was 10 milligram per deciliter. The doctor prescribed a drug for the treatment. Which of the following drug is likely to decrease neutrophil recruitment to inflamed tissue? So I'm waiting for your answers. Waiting for your answers. Yes, so here the answer is the drug which decreases neutrophil chemotaxis is none other than colchicine. Yes, many have answered. Akash, Harshil, yeah. Now colchicine inhibits microtubule polymerization, and because of that it decreases the neutrophil chemotaxis. What about the other option? Lesinurad is a uricosuric drug which increases uric acid excretion in the urine. It's a uricosuric drug. It's a uricosuric drug. Can you tell me other drugs which are uricosuric? They are probenecid, then benzbromone, and sulfenpyrazone. So these are the uricosuric drugs. What about ras-buricase? The drug ras-buricase is nothing but it is a recombinant enzyme. So this enzyme will convert uric acid into allantoin, and it's a recombinant enzyme of uric acid oxidase. So that is ras-buricase, and ras-buricase is used for hyperuricemia condition. It is for hyperuricemia condition. So we have one more drug called pegloticase that is approved for chronic gout. What about febuxostat? Remember guys, anything ending with stat will be an enzyme inhibitor. The purpose of that drug will be enzyme inhibition. So it inhibits mainly an enzyme called xanthine oxidase. So it inhibits the enzyme called xanthine oxidase. Now can you tell me one more drug which inhibits this enzyme xanthine oxidase? I'm waiting for your answers. Come on. Yes, Arshil Mehra, you are right. Even losartan is uricosuric. Yes, Akash, you are right. This ras-buricase, it is also used for tumor lysis syndrome where you see hyperuricemia. There it can be used. Yes, you're right. Now you have to tell me, we also use painkillers, that is NSAIDs for gout. Now tell me which NSAID is contraindicated in gout. Which one? Which drug is not used? Can you tell me? Yes, Sai Gaurav. Which is a xanthine oxidase inhibitor? One more. It is none other than, yes, Akash, you are right, allopurinol. The drug is called allopurinol. So which NSAID should not be used in gout? Which NSAID should not be used in gout? Come on. Yes, I will be very happy to get your answers. The NSAID which should not be used in gout is aspirin. Why not aspirin? Because aspirin itself increases uric acid levels. So almost all the NSAIDs are used, but one NSAID which is not used in gout is aspirin because it increases uric acid. So in this question they have asked which is the one which decreases neutrophil recruitment, that is means chemotaxis. The answer is A, colchicine. That is the answer, guys. So in one of the MCQs we have tried to cover most of the points which is important in the gout. Okay, yes. So let us move on to the next question. Question number 9. Drug of choice for treatment of congenital condition shown in the photograph is. So if I expand this photograph, you can see this is the aorta and this is the pulmonary artery, and there is a connection between two, and that connection is what we are showing you, and that is called patent ductus arteriosus, PDA. Now what is the drug which is used to close that PDA? So we are asking you the treatment for closing PDA. Now misoprostol, indomethacin, carbaprost, alprostadil. To close a PDA, you have to use NSAIDs. The NSAIDs that are used to close it are indomethacin. You can also use ibuprofen. And one more is aspirin. Right. Now, what is the one which is used to open PDA? The one which is used to open PDA is called alprostadil. The drug is alprostadil. So when you read the question, you should be very careful to answer this. The drug which is used to close is NSAIDs, and the one which is used to open is prostaglandin. So it is alprostadil. So coming to the answer, they have asked you the treatment of congenital condition is, answer is indomethacin. B, indomethacin. What about other drugs, misoprostol, carbaprost? To close, what we use is alprostadil. So let me give a list of prostaglandins what we use in therapy. I have made a list for you. Now, prostaglandin E1 preparation is called misoprostol. So, misoprostol is used for peptic ulcer disease. We use it in medical termination of pregnancy and also for postpartum hemorrhage. So, these are the uses of misoprostol. Coming to alprostadil, which is a PGE1, we use it in the treatment of erectile dysfunction and also to keep PDA open. Now tell me guys, which condition you want to keep the PDA open? Usually it is kept open whenever you are doing a surgery, that is a transposition of great arteries. Until surgery we want to keep it open. Now moving on to the dinoprostone, carbaprost and dinoprostone. PGE2 is 1. This is 1 and this PGE2. F2 alpha is carbaprost and dinoprost. These are used mainly for postpartum hemorrhage and abortion. So guys, you tell me, can we use carbaprost and dinoprost in a patient with bronchial asthma? Yes or no? I am waiting for your answer. Yes or no? Harshil Mehta, please answer. Akash Mehdi. Now coming to the other preparation, latanoprost, bimetoprost, toprost, uniprostone, they all are used for glaucoma. So they can increase the uveicular outflow, so they are used in glaucoma. The PGE2 analogs are epoprostinol, treprostinil, iloprost. They are used for pulmonary hypertension. So my question was, can we use carbaprost, dinoprost in asthma? Yes, Sai Gaurav, it is right. Transposition of great arteries, we use it. So can we use it in bronchial asthma? No, because this PGF2 alpha is a bronchoconstrictor. So better avoid this carbaprost, dinoprost in a patient with bronchial asthma. So you have to take a history before giving them to a patient. If they are asthmatic, don't use carbaprost or dinoprost. Okay. So this is a list I had to give you. And this is a question. The answer is B, indomethacin, guys. That is the answer for this. Moving on to the next question. Question number 10. Mr. Swami, aged 75, has heart failure. And he is on medication, that is telmisartan 20 mg and metoprolol. So heart failure, we are using telmisartan and metoprolol. He comes to the OPD with complaints of shortness of breath, increasing pitting ankle edema, and he has 1.5 kg of weight gain over the last 3 days. He is stable and has no chest pain. He was started on furosemide. The drug acts by following mechanism. So you have to find out, it's a lengthy question, but penultimately if you read the last line, you are going to find out what is the question. It is asking what is the mechanism of action of furosemide. Is it a carbonic anhydrase inhibitor? The drug which inhibits that is acetazolamide. So the drug is acetazolamide. It can be dorzolamide or brinzolamide. The sodium potassium 2-chloride cotransport inhibitor. It is the loop diuretics. And the loop diuretics are furosemide, torsemide, bumetanide, and ethacrylic acid. So here the question is directly asking you what is the mechanism of furosemide. Yes, it acts on the sodium potassium 2-chloride symport. Yes, many have answered. Lasix, B, Arshil, Akash, Sayant, Tan Basu. I want you to ask you one more question. Which site of the nephron will they work? Loop diuretics. I'll be very happy if you're answering that. The sodium chloride transport inhibitors are thiazides, and the aldosterone receptor antagonist is the spironolactone. So the drug is spironolactone. And one more drug is eplerenone. So these are aldosterone antagonists. The major site of action of acetazolamide is in a PCT. The thiazide is in early part of DCT, and spironolactone and eplerenone is mainly on the collecting duct. What about thick? Loop diuretics, I asked you this question, guys. Its main site of action is thick ascending loop of Henle. So we are missing two more diuretics, the epithelial sodium channel blocker, and they are nothing but amiloride, and one more drug is triamterene. And one more diuretics is osmotic, and that is called mannitol and glycerol. So yes, Rohit Sharma, you're right. Arshil, you're right. Ascending thick limb, very good. Now, can you tell me where you should not use mannitol? Two contraindications of mannitol, which is commonly asked in your exams. Commonly asked in exam, which condition mannitol is contraindicated? You answer that. Now, this is a patient with chronic heart failure. We are using telmisartan and metoprolol. Now, when we use beta blockers, what happens? Beta blockers decrease the contraction of the heart. Now, when they decrease the contraction of the heart, sometimes there may be congestion that will lead to shortness of breath, edema will increase, and edema increase will cause weight gain. So in that cases, we have to reduce the dose of metoprolol or stop it. That is what we do. So my important aspect I want to tell you is, in managing chronic CHF, what are the drugs which decrease mortality? The drugs which decrease mortality are the spironolactone, then we have the AAC inhibitor or ARBs or ARNI, then hydrazine plus ISDN, then we have ivabradine and beta blockers. So only these drugs can decrease mortality. Can a furosemide decrease mortality? No. Yes, many have answered it. Mannitol, remember two important complications. They ask you where it is contraindicated. Mannitol should not be used in two important things. One is pulmonary edema. It is contraindicated, not used. And whenever there is intra-bleeding, intracranial, that is cerebral hemorrhage. And whenever there is an established renal failure, these are three conditions where you should not use mannitol, guys. Now, my question is, will digoxin decrease mortality in CHF? Will digoxin decrease mortality in chronic CHF? Yes or no? So, waiting for your answers. Yes or no? Come on. Yes, Sayantu Basu, you're right. AC, ARB, beta blockers, aldosterone antagonists. So, they can decrease the mortality. So, will digoxin decrease mortality? So coming to this question, we have already answered this question. The answer for this is sodium potassium 2-chloride co-transport inhibitor, that is furosemide. So you answer me the digoxin part. Coming to question number 11. A 55-year-old male patient was having symptoms of excessive thirst and excessive urination, and ADH levels were very, very low. Which of the following drug will help in above condition of the patient? So these are case-based questions. You have to approach this. So first of all, patient is having polyuria and excessive thirst is polydipsia. So this will point towards the patient is having diabetes insipidus. So diabetes insipidus, remember there are two important types. One is the central diabetes insipidus and the peripheral. So in central, there is no ADH or very less ADH. And in peripheral, there is ADH, but that doesn't work on the V2 receptor. So what to do for central ADH, central diabetes insipidus? No ADH, give ADH. So how do you give the ADH? It is by desmopressin. For peripheral diabetes insipidus, the drug of choice is thiazides. So we can use thiazides for this. So they have asked it clearly, patient is having polyuria, polydipsia, and as told that ADH is very, very low. So it is a central diabetes insipidus. The drug of choice is Desmopressin B. Suppose the same question was asked and they have given ADH levels are normal, then it is peripheral, or we call it as nephrogenic diabetes insipidus, then the answer would have been the thiazide. Now, if the question was SIADH, syndrome of inappropriate ADH, so in that case, ADH is high. It is high. So that will act on V2 receptor and produces the symptoms. So what is the drug of choice is to block that, and we use V2 receptor antagonist. They end with Vaptan. For example, Tolvaptan. So that will be the drug of choice for this. What about terlipressin? Terlipressin will mainly act on the V1 receptor. It is V1 selective drug. So where do we use that? It is mainly used in managing esophageal varices. So don't mix that. But desmopressin is V2 selective. It is only used for that. And terlipressin is only used for esophageal varices. My question, guys, thiazides, can we use it for central diabetes insipidus also? Yes or no? Please answer that. Can we use them for central diabetes insipidus? Yes or no? Please answer that. So answer for this question I have told you already. It is desmopressin. I'm waiting for your answer. Yes, Arshil Mehta, very good. Sayantu Basu, Vaptans, very good. Shivam, Chitranj, Shivam. Yes, many are answering well. Happy with your answers. So please continue with that. Yes, come on. Can we use thiazides in peripheral diabetes insipidus? Waiting for your answers. Yes, you can also use them in central, but for central, drug of choice is desmopressin, but peripheral, the drug of choice thiazides. We can also use thiazides in central diabetes insipidus also. Right. So moving on to the next question, question number 12. A 15-year-old male patient has heart failure and was on diuretic therapy. He developed hyperkalemia when an AC inhibitor was combined with this diuretic, identifying the offending diuretic. So patient was having heart failure. You know that chronic heart failure, we start with either AC inhibitor or ARBs. So he is also taking a diuretic and he is having hyperkalemia. So you have to identify the offending diuretic. That means which can also cause hyperkalemia. Remember, furosemide is a loop diuretic, and the main problem with that drug is it can produce hypokalemia, magnesemia, calcemia, and natremia mainly. Along with that, it can produce metabolic alkalosis and decrease in ECF volume. Right, it can decrease ECF volume and ototoxicity. So this is the adverse effect. Now coming to indapamide. Indapamide is a thiazide diuretic. It can produce same hypokalemia, magnesemia, and sodium can be decreased, but here it will not decrease calcium, it will increase calcium. So it can cause hypercalcemia, that's the difference. But it can also cause metabolic alkalosis. It can decrease ECF, but it can produce sexual dysfunction. Indapamide. Similarly, we have hydrochlorothiazide, which can also cause the same. This is also thiazide diuretics. Coming to spironolactone can increase potassium because the name itself is telling you it's a potassium sparing diuretic. Along with that, it can produce metabolic acidosis, then gynecomastia. So these are the problems what we have with spironolactone. So most of the options what we are writing is they are decreasing potassium, but only thing which increases potassium, hyperkalemia, is spironolactone. But why the potassium increased? Because the AC inhibitors also produce that. They can also produce two important problems. One is dry cough and angioedema. So they can produce dry cough and angioedema. Along with that, they can increase potassium. They can produce rash, decrease BP, and altering the taste, that is called dysgeusia. So because this also increases potassium, that's why this is the answer. If you are using ACE inhibitor with spironolactone, the potassium level increases. Now tell me guys, can I use ACE inhibitor in a pregnant? Yes or no? Can I use ACE inhibitor in a pregnant woman? Yes or no? That is my first question. Yes, suppose a patient with ACE inhibitor develops dry cough. What is the next step? The question, second number question is, if a patient with ACE inhibitor develops dry cough, what is your next step? What will you do? Waiting for our answer. Yes, tell me. Yes, for the first one, no, that is fine. But what happened to the second question? What happens when we use ACE inhibitor in a patient and develops dry cough? Or the next step is to change to ARB. Change to ARB because the ARBs will not produce dry cough because they don't inhibit bradykinin. They don't inhibit bradykinin. That's the reason why we do that. Yes, Rohit Sharma, you're right. Change to ARB. Yes, Ayant, you're right. Change to ARB. So here the question, the answer for that question is spironolactone. Moving on to the next question. Mr. Basu is 66-year-old ischemic heart disease patient. He is on tablet aspirin, clopidogrel, and atorvastatin, isosorbate dinitrate, and omeprazole. What would be the possible consequence of this? Is a question. Loss of effect of atorvastatin as omeprazole antagonist statins. Loss of efficacy of aspirin as acid is required for its action. Loss of efficacy of clopidogrel as omeprazole prevents activation of clopidogrel. Less adverse effect as omeprazole reduces adverse effects of atorvastatin. So patient is taking multiple drugs. Now number one, aspirin. You know that aspirin is an antiplatelet drug. Even clopidogrel is an antiplatelet drug. Nowadays, for IHD, we use dual antiplatelet therapy and we use statins to prevent the plaque progression. And whenever the patient has ischemic heart disease, to decrease the preload and increase the working capacity, we use isosorbate dinitrate. Now, along with that, patient is also taking omeprazole. What is the main drawback is the question. So what happens when we give omeprazole? First and foremost, understand what is clopidogrel. It's a P2Y12 inhibitor. It's a P2Y12 inhibitor. It's an antiplatelet drug. So clopidogrel belongs to P2Y12 inhibitor. This clopidogrel is a prodrug, and after metabolism, it will give rise to the active form. And this metabolism is done by none other than cytochrome 2C19. Suppose the patient is taking omeprazole. The omeprazole can inhibit this enzyme CYP2C19. So if that enzyme is expressed or inhibited varies by omeprazole, what happens? Clopidogrel, which is a prodrug, will not become active. So even the patient is taking clopidogrel, it will not work because omeprazole will inhibit that. Similarly, please note down this. CYP2C19 is also genetic mediated. Even the people who don't have that enzyme will not be able to convert clopidogrel to active one. So coming to the question, let us read the option. The option is loss of efficacy of clopidogrel as omeprazole prevents the activation of clopidogrel. This is the right answer. This is the right answer for this question number 13. Okay, yeah. So what is atorvastatin? It is an HMG-CoA reductase inhibitor. What is isosorbate dinitrate? It is a nitric oxide donor. So it releases nitric oxide and that will act on the veins and decreases preload. Okay. Moving on to question number 14. A 45-year-old man had performance anxiety and migraine headache. Propranolol was used in this patient. What comorbid condition listed below? You should be very cautious while using propranolol in this patient. Is it essential tremor, glaucoma, classic or stable angina, and diabetes? So which one should be a contraindication for use of propranolol? So first of all, anything ending with LOL, it's a beta blocker. It's a beta blocker. Now we have the cardioselective beta blocker and non-selective beta blockers, and the drug is propranolol. So we use propranolol in conditions such as glaucoma, akathisia, migraine prophylaxis, essential tremor. We use it in thyrotoxicosis, infantile hemangioma, performance anxiety, pheochromocytoma, as well as we use it in portal hypertension. So patient is having migraine and performance anxiety, that's why we have used propranolol. So propranolol can work on all these conditions, but you remember when we use beta blockers, they are contraindicated in certain conditions. What are the contraindications of beta blockers? They should not be used in peripheral vascular disease and prinzmetal angina. And they should not be used in diabetics, because in diabetics they produce hypoglycemic unawareness. Hypoglycemic unawareness. Right? They are not used in AV block. Then they are not used in asthma or COPD patients or in a patient with bradycardia, because they can also decrease the heart rate. And they are not used in acute heart failure. So these are the contraindications of beta blocker. Now, can we use it in essential tremor? Yes. It is a drug which can be used in essential tremor. Glaucoma can be used? Yes, you can use it in glaucoma. Now, can you tell me some of the beta blockers which are used in glaucoma? I'm waiting for your answer, Sayantu, Arshil. What are the beta blockers used in glaucoma? Can we use it in classic or stable angina? Yes. We cannot use it in prinzmetal angina. Why? Because in prinzmetal angina, already there is spasm of the coronaries. Now, when there is spasm of coronaries, what happens? The alpha 1 will try to constrict and beta 2 will try to dilate. So if I block this action of beta 2, there is unopposed alpha action and the vasoconstriction will worsen up. So that's why it is not used in prinzmetal, but it can be used in classical or stable angina. But propranolol should not be used in diabetic because it produces hypoglycemic unawareness. I asked you what are the beta blockers used in glaucoma. Yes, timolol, cardiolol, levobunolol, and bitoxolol. So these can be used in glaucoma patient. They decrease aqueous humor production. So here in this question, which condition the patient should be cautious is in diabetics because of hypoglycemic unawareness. Moving on to question number 15. Which of the following is the most appropriate drug to use for the patient described in the following scenario? Yes, you are right. Many have answered it. You are right. So captopril. Can we use captopril in 60-year-old man with diabetic nephropathy? Can we use it? What is captopril? Remember, anything ending with pril is a AC inhibitor. So AC inhibitors, the advantages, they can decrease microalbuminuria. So they can decrease microalbuminuria. So this is very, very important in a patient with diabetic nephropathy, where you have to decrease microalbuminuria. Second, they also decrease intracranial glomerular pressure, which is useful in CKD. So you can use ACE inhibitors in a diabetic patient, you can use it in CKD, and even a patient having only microalbuminuria, you can use ACE inhibitor or you can use ARB. So this is the right scenario, you can use it. But let us go to the next scenario, nitroprusside. Nitroprusside, it's an IV drug and it's a nitric oxide donor. Now it is an equal dilator of artery and vein. Can we use nitroprusside in a 50-year-old man with BP of 140/95? Now the BP of 140/95, whether you know the grading or not, if you see that 140/95, it's around mild variety of hypertension. For mild hypertension, then who will give an IV drug? Now nitroprusside is a drug which is used for hypertension emergency. Hypertensive emergency. It's not used for routine therapy. Nobody will come every day and take this IV injection for hypertension. Now can you tell me guys, how do you tell whether it is a hypertensive emergency or urgency in a case history? How will you define that? Is it an emergency or urgency? So you tell me that and I will come back to that question. Come to the option C, losartan in 29-year-old pregnant woman. No, because ACE inhibitor, ARB, even renin inhibitors are contraindicated in pregnant women because of teratogenicity. So pregnant women should never be given ACE inhibitor, ARB or renin inhibitors. The other drugs which are contraindicated in pregnant women are sodium nitroprusside. The reason is it releases cyanide. One more is spironolactone. Now why can't we use spironolactone in pregnancy? Anybody? I'm waiting for your answer. Propranolol, 40-year-old patient with peripheral vascular disease, just now we discussed. A beta blocker should not be used in peripheral vascular disease because peripheral vascular disease already there will be vasoconstriction. And if I use beta blocker, the constriction will worsen up. So emergency, irrespective of high blood pressure, that is 180 or 120, there will be end organ damage. So emergency, remember, for end organ damage. Urgency, the BP will be high, but without any end organ damage. Right. So I was asking you why spironolactone is not used in pregnancy. Why? Anybody? Why spironolactone is not used in pregnancy? Come on. You know that spironolactone is also an androgen antagonist. So what happens if we give it to a pregnant woman? If the baby is male fetus, so this male fetus requires testosterone. If you block the androgen receptor, it will lead to feminization of female fetus. So that's why we don't use spironolactone in pregnancy. Why don't we use atenolol? Because atenolol increases small for gestational age. We don't use thiazides also because thiazides can cause decrease in uteroplasmal circulation. But teratogenic drugs are ACE inhibitor, ARBs, renin inhibitors, as well as spironolactone and sodium nitroprusside. Yes, guys. So the answer is A, captopril. That is the best one in a clinical scenario. Moving on to the next question, number 16. A 28-year-old pregnant. So when you read the case, please read whenever they give woman, you have to check whether she is premenopause, she is menopausal, or she is a reproductive age, or she is pregnant, she is lactating. So any woman case history, you should read that. So she is a pregnant woman and she is under second trimester, came to routine checkup. Her BP was 190/110 millimeters of mercury and she complains of blurring of vision. What is the drug of choice for her hypertensive condition? So BP of 190 and blurring of vision, maybe retinal hemorrhages, there is something called end organ damage. So she has come with hypertension emergency. So in a pregnant woman, what is the best drug? Can we use enalapril? Enalapril is not used in emergency because enalapril is a prodrug. Now can you tell me A derivative of enalapril which is used in hypertension emergency. Waiting for answers, guys. So in a pregnant woman, the drug of choice is labetalol. You can use labetalol intravenous. That can be used. Nitroprusside, I told you, it produces cyanide, and that's why it is not used in pregnant women, even though it is a drug used in hypertension emergency. Chlorthalidone is a thiazide diuretic. It decreases uteroplacental circulation. That's why thiazides are not indicated, and they are not useful in emergency conditions. You can use lube but not thiazides. Yes, enalapril. What is the derivative of enalapril used in hypertension emergency? It is called enalapril. So we have a separate drug, enalapril, which can be used for hypertension emergency, but we cannot use enalapril. But can we use enalapril in a pregnant woman? No, even that is contraindicated. So hypertension emergency in pregnancy, the drug of choice is labetalol. Even for hypertension in pregnancy, the drug used is labetalol. Right. So what is the drug of choice for eclampsia? Anybody? What is the drug of choice for eclampsia? Yes, Arshil Mata, you're right. Enalapril. What is the drug of choice for eclampsia? So can you tell me what category does teratogenic drug belong? Teratogenic drugs belong to either whether it is Schedule X or Category X. Anybody? Does it belong to Schedule X or Category X? The drug of choice for eclampsia is magnesium sulfate. Now teratogenic drug is Category X. So if the drug is Category X, that means teratogenic. For example, thalidomide, warfarin, phenytoin, lithium, all those belong to this Category X. Schedule X is different. Schedule X is going to be called for drugs such as ketamine and amphetamine. So those which are narcotic drugs, they come under Schedule X. But many students confuse this Schedule X and Category X. So Schedule X is a drug schedule. It is similar to Schedule H. So Schedule H will tell you drug to be prescribed by registered medical practitioner. Yes, Shivam, you're right. It is Category X for teratogenicity. Schedule X is the one which is there in drug label. Now in hypertension emergency, the first choice of drugs what we use nowadays is nicardipine, so if it is pregnant, we use labetalol. Otherwise, you can use nicardipine IV, that can be used. Yes, Sayan Basu, you're right. So moving on to the question number 17. A 45-year-old man has MI and is being treated for same in emergency department. He suddenly develops ventricular tachycardia. The best drug to treat this arrhythmia is. So remember, whenever there is MI, myocardial infarction, patient is prone for either he may be prone for acute heart failure or he may be prone for arrhythmias. So he may be prone for arrhythmias. Now sometimes what happens, we use to prevent arrhythmias, we can use prophylactically beta blockers. The most common beta blocker what we use is metoprolol. But if the patient develops arrhythmia, for example, he develops MI induced ventricular tachycardia, the drug of choice is you can use either lignocaine or you can start with amiodarone. Lignocaine and amiodarone are the best drugs. So the answer is here, lignocaine. So can we use lignocaine prophylactically? Can we use lignocaine prophylactically? Like we use beta blocker prophylactically. Can we use lignocaine prophylactically? No. It is not a drug to be used prophylactically. Only when arrhythmia develops, then you have to use lignocaine. But metoprolol can be used prophylactically. Suppose a patient has digoxin induced ventricular tachycardia. Now tell me guys, what is the drug of choice? Waiting for your answers. So until that, I will tell you some of the other drug of choices. You need to remember SVT and PSVT. The drug of choice is adenosine. If the patient is having atrial fibrillation or atrial flutter, the drug that we use is either beta blocker or you can use CCBs. Now remember one more point, adenosine causes bronchoconstriction. So a patient having SVT, PSVT comes with asthma, then we cannot use adenosine, then the drug will become verapamil. Now tell me, what is the drug of choice for digoxin-induced VT? It is lignocaine. This was a recent question in FMGE exam. What is the drug of choice for digoxin-induced VT? It is lignocaine. Why can't we use amiodarone? Amiodarone itself increases digoxin toxicity. Amiodarone itself increases digoxin toxicity. That's why we don't use it. Suppose there is digoxin-induced SVT, supraventricular tachycardia, then we can use beta blockers. Can we use verapamil? No. Verapamil increases digoxin levels. That's why we don't use this. Cyan basu, yes, if the digoxin toxicity is too high, we use digibine. But for arrhythmia, I am asking you for arrhythmia, the drug used is lignocaine. So digoxin can itself cause arrhythmia, and digoxin can be used to treat the arrhythmias which are present above the ventricle, such as atrial fibrillation. It can be used atrial flutter. It can be used in SVT, PSVT conditions. But most commonly it is used to treat atrial fibrillation. Now what are the class of antiarrhythmics we have? The class of antiarrhythmics which is there are class 1, class 2, class 3 and class 4. And the last one is miscellaneous. The class 1 drugs, they are sodium blockers. Class 2 drugs are beta blockers. Now class 3 are potassium channel blockers. Class 4 are CCBs. And miscellaneous we have digoxin, atropine, magnesium sulfate. Then we have isoprenaline and adenosine. In class 1A we have 3 subcategories: 1A, 1B and 1C. 1A and 1C you can use for both atrial and ventricular arrhythmia, but 1B it is only used for ventricular arrhythmia only. For example, 1B drug is lignocaine. Lignocaine is not useful in atrial arrhythmia, it is only to treat ventricular arrhythmia. Now for bradycardia and AB block, the drugs used is, one is atropine and one more is isoprenaline. So these are the 2 drugs which can be used in bradycardia and AB block. Okay, so these are the things what I had to cover to you. Yes, Arshil Mehta, you're right. So we're done with that question. Let us move on to the 18th question. A 57-year-old lady came with chief complaints of fatigue, sluggishness and gain in weight. She is sleeping for many hours in a day. She has been taking T4 since 17 years. So she is taking levothyroxine. T4 is levothyroxine. And without any side effects and disease symptoms of hypothyroidism. Recently, she has been diagnosed with arrhythmia and on antiarrhythmic drugs. What is the cause of her current condition? So, importantly, if you read the case, 57-year-old, complaints of fatigue, sluggishness, gain in weight, and she is already hypothyroid. So, which antiarrhythmic can aggravate hypothyroidism is the question. Now remember, lidocaine belongs to class 1B drug and it is one of the safest drugs. But if you increase the lignocaine toxicity can cause CNS and CVS problems. So CNS, it can cause seizures. CVS, it can itself cause arrhythmia. That is with the high dose. Normal dose, nothing will happen. So what is the antidote for this lidocaine overdose? Anybody? Is there anything antidote for this? I'm waiting for an answer. What about amiodarone? So amiodarone is a broad spectrum antiarrhythmic. Even the adverse effects are very broad. What are the adverse effects we have? The adverse effect what is seen with that is the thyroid dysfunction. So it can produce thyroid dysfunction. That means it can produce both hypo and hyperthyroidism. It can cause liver cirrhosis and pulmonary fibrosis, and particularly affects type 2 pneumocytes. So that's why when we start a patient, we have to monitor thyroid function test, liver function test, and pulmonary function test. Not only this, it will also cause peripheral neuropathy, and it will cause deposits in the cornea. We call it as cornea verticillata, or we call it as vortex keratopathy. It can also produce smurf skin, that is blue man syndrome. So obviously the question is clear that patient is having hypothyroidism. Again, when we start amiodarone, the hypothyroidism may increase. So the answer is B, amiodarone. B, amiodarone, that is the right answer. So in the recent exam, they had asked the same question. So patient had pulmonary interstitial pneumonitis. Which antiarrhythmic should be stopped? Yes, there also it is amiodarone, should not be used. Procainamide belongs to class 1A antiarrhythmic. The major drawback of this drug is it undergoes acetylation and it produces drug-induced lupus erythematosus, DLE. Verapamil is a CCB which belongs to class 4 antiarrhythmic. It's a class 4 antiarrhythmic, and it is used for mainly to treat SVT, PSVT, atrial fibrillation, and atrial flutter. So here the answer for this question is B, amiodarone. Amiodarone is the one which can cause all this problem. Now can you tell me which arrhythmia we cannot use amiodarone? Can you tell me 2 arrhythmias where we cannot use amiodarone? Yes, the antidote is intralipid. It is called intralipid. That is the one which we use in local anesthetic toxicity. This was a recent question that was asked. Right. Can you tell me which arrhythmia we cannot use amiodarone? Amiodarone cannot be used in one is digoxin induced ventricular tachycardia, and whenever there is prolonged QT interval, because the class 3 drugs, they block potassium channel and they can increase QT prolongation. So these are 2 arrhythmias. Otherwise amiodarone can be used for almost all the arrhythmias except these 2. Yes, Arshil, Ajay, you are right. I mean, you are giving the right answers. Now, when I take up digoxin, I want to tell you digoxin aspect. Digoxin can cause all type of arrhythmias. So, digoxin can cause all types of arrhythmias except 2. It can produce all arrhythmias except 2. Except atrial flutter and Mobitz type 2. Yes, you are right, Ajay Navin. That is torsades de pontis. So long QT syndrome. Polymorphic VT with long QT is nothing but torsades de pontis, where we cannot use amiodarone. Very good. Now, what is the most common arrhythmia we see with digoxin? The most common arrhythmia what we see is called ventricular bigeminy. Then what is the most specific arrhythmia which we see with this digoxin is atrial tachycardia with AB block. So that is the most specific arrhythmia what we see. If you see the ECG and we see this arrhythmia, that means it's the most characteristic arrhythmia. So the ventricular rate becomes normal because of AB blockade. The atria will increase the excitability, so there will be atrial tachycardia. So that is about digoxin. Yes, let's move on to the next question. Question number 19. A 48-year-old man was discharged after recovering from COVID-19. His D-dimers levels were very high, so the physician decided to put the patient on oral anticoagulant drug as prophylaxis. Which of the following oral anticoagulant act directly by inhibiting 10A? So they are asking you which drug inhibits 10A directly. Is it rivaroxaban, dabigatran, enoxaparin, or heparin? Now remember how to identify a direct 10A inhibitor. It ends with hexaban. It ends with hexaban. That means it's a direct 10A inhibitor. For example, I will give one more, apixaban. So the ban 10. So hexaban, they can remember them as hexaban. What about dabigatran? Dabigatran is a direct 2, that is 2A means thrombin inhibitor. It's a direct thrombin inhibitor. So most of the times during COVID-19, these were prescribed to a patient because they are oral drugs. So that's why these are called DOACs, directly acting oral anticoagulants. So these are called directly acting oral anticoagulant, that is hexabans and dabigatran. Can you tell me one more drug which can be given orally, anticoagulant drug? Now remember, the drug ending with parin is low molecular weight heparin. Low molecular weight heparin. So they end with parin, enoxaparin, dalteparin, nalteparin. So heparin and low molecular weight heparin, they activate antithrombin 3, and that will inhibit the factors. For example, in low molecular weight heparin case, if the 10A is inhibited more than 2A, in the case of heparin, the 10A and 2A are equally inhibited. So remember, they don't inhibit the 10A directly. They will activate antithrombin 3, and that will inhibit 10A. Similarly, we have one more synthetic heparin. It is called fondaparinux. So this fondaparinux, it will also activate antithrombin 3, and then it will inhibit 10A only. So is it a 10A inhibitor? No. Direct 10A inhibitor? No. It is an indirect 10A inhibitor. I asked you guys one more oral drug which can be used is warfarin. But it's not a novel agent. It's there from so many years. So these DOACs are also called as NOVACs, that is novel oral anticoagulants. And warfarin is very old, and it acts by inhibiting factors 2, 7, 9, 10, which are required for coagulation. Now the next question which is commonly asked is, which of them require lab monitoring? Heparin requires lab monitoring, and you are required to do APTT commonly. Now does low molecular weight heparin require that? No. Dabigatran? No. Rivaroxaban? No. Now who would require that? Parenteral direct thrombin inhibitors such as hirudin, lepirudin, argatroban, they require monitoring of both APTT and PT. What about warfarin? Does it require any monitoring? Yes. It is mainly the INR, that is prothrombin time, international normalized ratio, that is what we do. Now what is the antidote for the following? Rivaroxaban, we have something called and-hexanate alpha. Dabigatran, we have idarucizumab. Heparin and low molecular heparin, we have protamine sulfate. Fondaparinux doesn't have an antidote. Parenteral direct thrombin inhibitors don't have antidote. What is the antidote for warfarin? I am not going to answer. You have to tell me the answer, guys. What is the antidote for warfarin? Yes, Sarshil Mehta. Right. So what is the antidote for warfarin? So the antidote for warfarin is none other than vitamin K. Suppose the bleeding, patient comes with bleeding, how to reverse the bleeding? Vitamin K will not work immediately. It takes time to work. So when the patient comes with bleeding, then for that patient we use something called 4-factor prothrombin complex concentrate. So that is the treatment of choice. If they ask you antidote, then answer is vitamin K. Otherwise, if the patient has come with bleeding, what is your next step? Should be 4-factor prothrombin complex. If that is not there, you can go for fresh frozen plasma. These are the answers which you can give. Yes, that is question number 19. Moving on to question number 20. So it's a simpler question. Drug of choice for diazepam overdose is it fomepizole? Now I told you, remember OO, so it is for alcohol poisoning. Whether it is ethanol, methanol, ethylene glycol, the antidote is this. Flunitrazepam, it is itself a benzodiazepine, we call it as tasteless benzodiazepine, which is mixed with the food and given to the rape victim, and it is used as date rape drug. So it is doesn't have any taste, and once the patient takes this, after that he will forget the events, so it will have high anterograde amnesia. So that's why it is used as date rape drug. Phenobarbital is a barbiturate. It doesn't have any antidote. So what do you do when there is phenobarbital poisoning? Either we can do one thing, do hemodialysis and remove the poison, right? So you can do hemodialysis and remove the poison. Or the second thing is you can do one more thing. It's an acidic drug. So tell me guys, what to do with the urine if it is acidic drug? I am waiting for answers. So the antidote for diazepam overdose is flumazenil. But what about phenobarbital? What is the antidote? Waiting for your answers. So if it is acidic drug, to remove that, what you have to do is you have to alkalinize urine. You have to alkalinize the urine. Okay guys, so we are done with the question number 20. So we have another 30 questions to go about, and I hope the speed is fine, you are understanding, the questions are getting better. So just put your comments here, and we'll be back. Now it is around 5:50, so we'll take a break of 10 minutes. We'll be back by 6:10 p.m. Okay, thank you all. We'll be back, and thank you for responding to the messages and to make this session wonderful. Thank you all. So we'll be back in 20 minutes.